Welcome everyone to tonight's webinar on psychological approaches to pain management. My name is Lindsay Code. I am the Vice President of Strategic Operations for the Sierra Sacramento Valley Medical Society. And I'm also the co-chair for the Sacramento County Opioid Coalition. You know, one of the goals that we have in working with the Sacramento County Opioid Coalition is that we'd like to help train primary care physicians and other providers as well on alternative methods to pain management. So this webinar is being recorded and it will be available on our YouTube channel at a later date. Tomorrow after the webinar, you will be emailed a link to a survey, and once you fill out the survey, you will receive 1 CME credit for attending tonight's webinar. Now, if you have any questions throughout the webinar, please use the Q&A function to ask them. At the end of Dr. Ortiz's presentation, we will be going over your questions. So let's introduce tonight's speaker. Dr. Ortiz is from San Jose, but she has traveled all over the world and has lived in Mexico, Japan, and Taiwan. After getting her undergraduate degree in psychology at the University of Michigan, she earned her PhD at the University of New Mexico in clinical psychology in 2015. While in grad school, she still managed to find time to teach spin class, to dance salsa, and to hike. Dr. Ortiz finished her clinical psychology internship at the Veteran Affairs Palo Alto Healthcare System. Afterwards, she completed a clinical psychology postdoctoral fellowship with an emphasis in addiction medicine and dual diagnosis and dialectical behavioral therapy at the University of Stanford. It is no surprise that Dr. Ortiz has been awarded several prestigious fellowships as well. Dr. Ortiz has worked with the Stanford University School of Medicine for almost 5 years. She is currently a clinical assistant professor at Stanford University in psychiatry and behavioral sciences, and she has her own private practice in San Francisco. So Dr. Ortiz, I'm going to turn it over now to you. Please take it away.
Thank you so much, Lindsay. Welcome, everyone. We'll just take care of the disclosures to begin with. So no faculty or members of the planning committee for this CME have any relevant financial relationships with ineligible companies. And I'd like to just begin with taking a moment to transition from whatever you were doing before now to just arrive here at this talk together this evening. So I live in a Pacific time zone, but I'm currently on the East Coast, so it's about 9 p.m. my time. So let's go ahead and just take a few breaths to just arrive here together, whatever time zone you might be in at the moment. This is actually the same practice that I do before I begin a session with a patient. So just taking a moment to notice that your body is breathing. Allowing a few full inhales and exhales right where you are. And just sensing the breath, whether it feels more present through the nose or the mouth. If your feet are on the floor, just feeling that contact with the floor and the sturdiness of the ground underneath. Sensing the rise and fall of the chest and the abdomen. Just allowing yourself to drop into this moment, to be here now. And no matter where the mind has been, seeing if it's possible to be there for these next 3 breaths as they're happening. Just breathing. And one more breath. Thank you for your willingness. So let's go ahead and jump in. I'll be briefly presenting a case example, And you can see the different tips and techniques from each of these modalities that I'll be sharing tonight. I obviously won't be teaching each of these therapeutic approaches in their entirety, but you can reference the handout on Dropbox via this link for additional resources. Okay, so starting with our case example, Serena. Serena is a 46-year-old coming in with long-standing idiopathic pain since her teenage years, as well as depression, insomnia, a childhood history of sexual abuse, passive suicidality in the form of thoughts of preferring to be dead. And she stated multiple times that she was sick and tired of being in pain all the time. She worked as a nurse in a cath lab until the year before she presented to treatment. And she has 3 children, limited financial resources, has been struggling to make ends meet. And she also carries diagnoses of fibromyalgia, depression, opioid use disorder, as well as a history of hydrocodone dependence, insomnia, and PTSD related to childhood sexual abuse. Okay, so if we jump in and look at some of the tools that we might use, thinking about just keeping Serena in the back of your mind as we're going through this case example. The first tool that I wanted to share is from motivational interviewing. So for those of you who aren't familiar with this approach, motivational interviewing is a person-centered counseling style. It's used to address the common problem of ambivalence about making a specific change. I won't be spending time on the theoretical underpinnings or the research base of these tools. I really wanted to just give you the clinical tools that you might be able to implement in your encounters with patients. So that's what we'll be focusing on this evening. Okay, so some of the critical tools that I wanted to share from motivational interviewing. So the first one is EARS. EARS is an acronym for the 4 client-centered skills and strategies that are central to engaging with patients. And these are the core skills of motivational interviewing. So they are elaborative questions, affirmations, reflections, and summaries. And these are the tools that will help you navigate the waters of behavior change with your patients. And I've included some examples of provider language here that you might use. I put that in italics. So for example, when asking elaborative open-ended questions as opposed to close-ended yes or no questions, questions like, why is it important to you to make this change? What do you want to look different in your life? What has the pain cost you? I find that this is an especially helpful question because we get an idea of the ways in which they've made their world smaller as a result of the chronic pain. For affirmations, motivational interviewing is really a strengths-based approach. So we're really going to want to highlight and be explicit about the strengths that we see in our patients coming in, often because they're coming in pretty demoralized and having experienced repeated failure attempts in coping with chronic pain or trying to get off substances in the past. So anything that you can emphasize or highlight to the patient that's a strength, we really want that to be a focus. So for example, you're doing a great job sticking with your opioid taper. Also for reflections, we are focused on reflecting back to the patient a very particular, not any language, but a very particular type of language that we call change language. So this is anything that they're expressing that's moving them in the direction of making a change to the target behavior. So for example, getting off of opioids. So at one point, Serena said to me, I know they won't prescribe me opioids forever. She was actually very concerned about this, that she would get cut off suddenly. So she actually was motivated to get off of opioids sooner. And so a reflection for that could be, it's really important for you to find other long-term solutions to deal with the pain. And she actually agreed with this. And that facilitated some joining and collaboration, and we were able to work together more effectively. We had a shared treatment goal. And then finally, summary. So we really want to be explicit. It's like we're gathering up, each reflection is a beautiful flower. And then at the end of the session, we present them with this bouquet of all of the take-home points, all of the things that we want to emphasize. And so, for example, so your top reasons for wanting to stay off of opioids are, and then repeating back those reasons to reinforce them. Okay, another motivational interviewing tool are the rulers. So as PCPs, if you only use one tool for motivational interviewing, I would recommend the ruler, because it gives you some of the most critical information in a short amount of time. It's one of our more efficient tools. And so, for example, the language around this could be on a scale from 0 to 10, 0 being not at all important to 10 being a top priority, how important is it for you to, and then whatever the target behavior is, to adhere to a pain management program, quit opioids, find ways to live a life you want, even if you have pain. And then we also want to ask about confidence, and as well, readiness, I think, can be optional, but I find importance and confidence to be critical, especially if you're short on time, emphasizing both of those. Because in Serena's example, it was actually clearly important for her to quit opioids. As I mentioned, she knew the likelihood of long-term prescribing was low, and she didn't want to get cut off suddenly. However, she actually wasn't confident that she would be able to quit successfessly. And so once we realized that that was the stuck point, then we were able to really target our interventions, my interventions in the session. I was able to really focus on what the problems, what the challenges were that really needed to be addressed. And we also want to ask for each question, asking a follow-up. So let's say, the patient says that they're a 7. So then you would say, okay, a 7, so that's pretty high up there. Why a 7 and not a lower number like a 2? And that language is important, because if you ask it in that order, then they will give you all of the reasons why it's important for them to change. But if you want to be careful not to flip it around and say, why not a 10? Because then they'll say, well, it's not a 10, it's not that important. There's other things that I want to prioritize in life. It's not the topmost thing for me. So you'll actually get what's called sustained talk. That's counterproductive. And then we can also ask, what would help you get from if they said something like a 3 to a 4, what would have to happen? Okay. Something else that I wanted to emphasize for motivational interviewing is this explicit focus on emphasizing the patient's autonomy. So I've actually worked with a number of PCPs who have expressed to me that accepting this pillar of motivational interviewing has really reduced their burnout. Because ultimately, patients are going to do whatever they want when they walk out of our offices, regardless of our instructions or our best wishes for them. So we do the best that we can as providers, but ultimately the patients are responsible for their own lives. And so the more we accept this, the greater that our quality of life will be, and the lower our burnout will be. And then patients will also likely feel less pressured and paradoxically be more willing to make change. There's also a great tool for motivational interviewing called Ask, Provide, Ask. So the first ask refers to inquiring about what they already know, so that we're not wasting time, especially in a 15 or 20-minute visit. Every moment is precious. So in this case, if we ask what they already know, we're not repeating ourselves. We're going over things that they're already aware of. So asking whatever it is that whatever that topic of focus is. So for example, what do you know about tapering off of opioids? And then the next part of that ask is, do you mind if I share some thoughts or tools or concerns, whatever you'd like to share with them about that? And then they 9 times out of 10 will say yes. And if it's a no, that's also helpful information, because you might need to backpedal and do some rapport building or kind of see what's getting in the way. But most of the time they'll say yes. And that yes is actually then your open door. Just by them having given you permission to share that information, they're much more likely to be receptive. And then the provide is actually sharing whatever it is that you want to share with them: psychoeducation, expertise, feedback from their test results. And then the final ask is really just getting a sense of how this is landing for them. What do you make of this? What do you think you'll do going forward? So that you can see, did what I share just fall on deaf ears? Or, are they really taking it in? Are we on the same page? There's a similar function with the end of session question. This can be pretty illuminating to really check in. Sometimes, when I have asked this, I've been very surprised that patients' take-home points were really different than what I had hoped they would be, but then that's a great point for me to stop and clarify. And so things like, what are you going to take away from today's appointment? What's the next step for you? What will help you, instead of your pain, be more in control this week? Okay, to keep us all awake at this hour, I've included a few check your knowledge questions. So please just read through this, and then I'll invite you to type your answer into the chat. And guesses are welcome. Totally fine. To this first question, which of the following is not an am I consistent strategy? Let's see if we have a few more guesses. I appreciate the participation. Okay. So if you guessed B, then you are correct. You need to stop taking opioids immediately. So that is not an am I consistent strategy. That's a directive. And of course, that can be used as necessary, especially in that ask, provide, ask format where you get permission so that they're more likely to be receptive versus tuning us out. But without that format, this would not be an am I consistent strategy. Okay. So our next set of skills comes from acceptance and commitment therapy. So this is a modality that combines behavioral and mindfulness strategies to increase values consistent behavior and to increase something called psychological flexibility or adaptability to reality as it is in this moment. To be able to work with what's happening more effectively and to move towards one's values. What matters to the person or gives them a sense of meaning. ACT uses metaphors and experiential exercises to try and get our patients into healthy contact with thoughts, feelings, and sensations that are feared or that are avoided. So for example, pain is often something that is really avoided by these folks. They understandably, right, it's very distressing, it's obviously painful, and so there's a lot of focus on doing whatever they have to do to get away from the pain at all costs. So ACT really helps to make some healthy contact with the pain. And it's a very action-oriented approach. And, as I mentioned, patients who are stuck in chronic pain get really active in the struggle of reducing pain rather than living a life of their choosing. And so one of the ACT metaphors is this idea of a tug of rope or a tug of war, and that we're getting them to drop the rope, this struggle that they're in with the pain. The idea is to help patients become more aware of how much energy and effort is going into this tug of war, and to see if they can shift out of that in some way or get more flexible. Right? Often they're caught in the struggle and they're not living their lives because they're solely focused on getting rid of the pain. And that's all that matters. And then their world gets very small. So the focus in ACT is really to help increase their willingness to allow for some pain so that they can move towards what matters to them. So if we take Serena, for example, so she had a value of being a good parent. And actually, I'll just say before I jump in with Serena, so this is called the ACT hexaflex, and these are the 6 core components of acceptance and commitment therapy. So values, really focusing on what matters to you, what makes your life feel rich and full and meaningful as you define it. Being present, or what we think of as mindfulness. Acceptance, which is also sometimes referred to as willingness, to accept some pain, to be willing to make space for certain thoughts or feelings that are uncomfortable. Diffusion is the ability to step back. So it's the difference between I'm having the thought that I'm a failure and I'm a failure. If we're just diffusing, we're trying to decouple and get a little bit of distance so we can look at and observe the thought or the experience. And then self as context is similar to the observer self. This one can be a little bit tricky to unpack, but you can think of this as the observer self. And then the commitment, what's the committed action that they're willing to take? So if I were following them around with a video camera, what would I see them doing differently? How would I see them moving through the world differently towards their values? So if we take Serena, she had the value of being a good parent, but she wasn't, to her, one of the things that was really getting in the way of being a good parent, and she felt a lot of guilt and sadness, was that she was missing her son's soccer games. And he was also very sad about that and very vocal about that. And she was missing her son's soccer games due to chronic pain and anxiety. And so we really worked through what's called dancing through the hexaflex, where we were working on diffusing or stepping back from the thoughts. So one of the thoughts for her was that I can't go to my son's soccer game if I'm having pain because I'll be stuck in bed for a whole week afterwards. It'll just be essentially crippling. And so she was really fused with that thought. She hadn't even tested it out to see if it was true in a very long time. She just believed that that was the reality. And so we got her to just notice that that was a thought, maybe a hypothesis, and could she test that out and see? And so, so this combines actually a number of different strategies. But basically, instead of, she had to bring some acceptance or some willingness to the pain and then commit to attending those games to see what would happen. And in attending those games, she was actually living her value of being a good parent. And when she had more willingness to just have the pain, to allow some space for that, it actually freed up some bandwidth for her to be able to engage more fully with the things that were important to her. She did start going to her son's games, and this was also a behavior activation strategy, which we'll talk about in a moment, and this improved her mood as well because of that. Okay, so essentially with ACT, I just want to highlight that it's much less about just focusing on making the pain go away and much more about getting disentangled from the thoughts, feelings, sensations, really helping patients move towards their value. So you want to start to get curious, where is their focus or their effort? Is the patient's life about trying to not feel pain, or is it about building a rich, full, meaningful life? You also want to start to notice what thoughts or stories that they're fused with. So I shared that example from Serena. Okay. So some questions to language this modality. What has the pain been keeping you from doing that's important to you? How would your life look different if you were more focused on what mattered to you instead of trying to feel less pain? So for her, it was things about, I'd be showing up for my son. I'd be there for my family members. I might feel more connected. I would feel proud that I was getting out of the house and doing things and, getting involved in certain organizations that were important to her. She was a member of the LGBT community and also Asian Pacific Islander. And so those communities, she had gotten really disconnected from those aspects of her identity, her culture, because of the chronic pain she had been isolating. And this idea, we say in ACT that ACT is about living life from the feet up, not the head down. So we're trying to get out of the stories and into taking observable action in their lives. And so if you're curious about what their values are, I chose the shortest values-based questionnaire that I could find, the Valued Living Questionnaire. So this is an inventory that you could consider adding to your intake paperwork so that when they're filling out symptoms-based measures, you could also get a sense of what their top 10 values are. And that could help inform some of their why about, because especially with chronic pain and especially with things like getting off of opioids, they need a really strong motivation to be able to compete with the reinforcement, that dopamine hit that they're getting from the pain medication and also the relief from pain. So it's doubly reinforcing. Okay. So question 3, what would not be an ACT consistent message to communicate to Serena? And I'll read these aloud this time just in case this isn't visible to folks for some reason. So A, let's concentrate on getting rid of this pain. B, I hear that you want the pain to go away. If you didn't have pain, what would look different for you? C, what do you care about? And D, would you be willing to have some pain in the service of pursuing the things that are important to you? So what would not be an ACT consistent message? Okay. So if you guessed A, you would be correct. Let's concentrate on getting rid of this pain. Again, that is not the focus of ACT. It doesn't mean that that's not important at all, but it's just not the primary focus of this modality. It's really about allowing space for uncomfortable thoughts, feelings, and sensations, some willingness to make room for that while they're moving towards or in the service of moving towards what matters to them most. Okay, so tools from cognitive behavioral therapy. So many of you are likely familiar with CBT or have at least heard of it. It's one of our most common psychological interventions modalities. So this really focuses on the interrelationship between thoughts, feelings, and behaviors. And that making small changes in one or more of these domains can facilitate more adaptive functioning. And so if we think about from CBT, I find this quite useful to actually just talk to them about the pain cycle from an educational perspective, to walk them through this, and then to ask patients about their own experience. Because patients might not have awareness of the interrelationships between their thoughts, feelings, and behaviors. And so we want to help them start to understand and become aware of those common patterns and that bi-directional engagement. And then to also just ask questions of them around, how does this fit for you? Where are you getting stuck? Where are you struggling the most? This can be really helpful to identify initial treatment targets. And then you can see where their challenges are. And then in this way, you're co-creating those treatment targets together. It's a more collaborative approach. Okay, so some other tools from CBT. So one that I'm very fond of is activity pacing. So essentially, we know that chronic pain patients often get into the cycle of overdoing and then avoiding activity for a period of time due to pain. And because they got, a day or a moment or part of a day of a little bit less pain or a little bit more energy, and then they really want to capitalize on that. And then they end up overdoing the things that have been piling up while they've been on the couch or in bed because of the pain. And then when they overdo and then avoid activity for a period of time, this can actually worsen mood and can even potentially result in deconditioning if that time period is prolonged enough, if the avoidance is prolonged enough. And then at that point, then they'll just start the cycle over again. They'll build up some momentum or get, a moment of less pain or more energy, and then they overdo again. And, we know that that's a cycle that's not productive, but often patients aren't aware of this, that to really zoom out and see the trend, that can be really eye-opening for them. They can fall into the cycle unwittingly. And so some languaging around this. Sometimes we can get into a cycle of overdoing one day and then underdoing or being wiped out the next day, which doesn't help long-term. Would you be willing to try doing some consistent activity like walking to help make more steady progress? And if they say yes, then what might be the benefits of that? So we're going back to motivational interviewing. And if they're telling me, well, I'd feel better, I'd be proud that I got out of bed that day. My family would also really, they would be happy too if I were getting more active, but not overdoing it and kind of getting out of this cycle. And so then they're the ones who are arguing for change, right? You can kind of take a back seat and allow them to step forward and make all of those arguments themselves, which is also going to be more motivating to them. Then we might have the exact same reasons or benefits that we would highlight, but it's so much more compelling when it comes from them. And then, once we get that commitment and those pros, then just asking, okay, well, how many days per week would you be willing to do that? And then just start mapping that out concretely together so that they can get a specific idea of how they would actually implement that. And that specificity makes it more likely that they'll actually carry it out. Okay. We also have relaxation training. And so for this, we want to provide a succinct rationale and then go right into an experiential component in the room with patients. We know, especially from CBT, that if you do the exercise or the homework that you're asking them to do with them a first time, there's a scaffolding that happens, and then they're more likely to actually carry it out outside of your office than if you just tell them to do it, but they've never done it before, they're less likely to carry that out. So a little bit of hand-holding is helpful at the beginning. And then you can also troubleshoot any barriers or any questions they have that come up for them. So for example, saying extra tension in the body can worsen pain, giving a little bit of psychoeducation. Let's practice taking 3 slow breaths together. In for 4 seconds, hold, out for 6 seconds. Good. So you get a little bit of positive reinforcement there. You're practicing it with them. And then you invite them to practice that on their own. Okay, a few more tools from cognitive behavior therapy. So one is smarter goals. This used to be SMART goals, but it's now been expanded, smarter goals. So we're really focusing on making the goals specific, measurable, attainable, relevant, time-bound. And I'm not going to go into unpacking each of those, just wanted to highlight this. And then the ER that's been added is evaluating it on a regular basis, and then rewarding it when achieved. So setting some kind of reward or positive reinforcement, ideally not substance related. And it doesn't have to cost a lot of money or any money really. You know, one of my folks just, she buys herself her favorite coffee, or, you know, she organizes a hike with friends. So some kind of reward if they achieve that goal, then it's more likely to be repeated. And then the R can also stand for revisited if it wasn't achieved, to actually troubleshoot. So this wasn't in the original SMART goals. Okay, and then cognitive restructuring. Oh, actually, one more thing that I'll say with the SMARTer goals. I would invite you to consider writing a behavioral prescription. So just like you would write a medication prescription, I think just having that behavioral prescription, one thing on a sheet of paper that patients can take with them, they're much more likely to remember. And for whatever reason, I've just seen that be really effective for folks. Okay, cognitive restructuring. So this is really about helping to highlight and to shift extremes in thinking. And, you know, especially with a fair amount of pain over a prolonged period of time, that can really shift how they feel. I'm never going to get better. This is always going to be so painful. Nothing will ever help. And so helping them to just notice if there are some of those extremes, or what we sometimes call distortions in thinking, and then helping them to just challenge some of those thoughts or evaluate the evidence for and against. So for example, when you tell yourself that you're always going to be miserable, how does that affect how you feel and what you get done? So they can start noticing those interrelationships between thoughts, feelings, and behaviors. Okay, and what would you tell a friend who is in the same situation, so that they can get a little bit of distance, and oftentimes they'll have better advice for their friends. And so that can actually make them more hopeful, right? If they would tell a friend something that was a more balanced thought or less judgmental or extreme. And then behavior activation, I mentioned earlier. So this is an intervention. It's actually the gold standard treatment for depression, gold standard behavioral treatment for depression. So this is really focused on getting patients active and engaged in pleasant, meaningful, and values-based activities. So getting them off the couch and back in touch with things that are reinforcing for them. So for example, it seems like you've taken a lot of enjoyable activities out of your life because of pain. That's understandable, but likely not making you feel better long-term. So what would you be willing to add back in this week that you enjoy? What do you miss about that activity? Right? And then they start recalling all of the things that were so important to them and getting in touch, and that can help build the motivation. I will say behavior activation and motivational interviewing pair very well together, because oftentimes it does take some MI to help get that momentum going and break the inertia. Okay, so now let's check on this one. So Serena states, I work better having one really productive day, even though I end up paying for it later. Which CBT technique would be most indicated? A, behavior activation. B, activity pacing. C, thought stopping. Or D, relaxation training. Let's see. Okay, wait for one more response in the chat. You can't fall asleep before I do. I appreciate that participation. There we go. So if you guessed B, you are correct. That we're trying to break that cycle of overdoing and underdoing in order to facilitate more consistent activity long term. So this will help keep their mood more stable. They'll feel more productive over time. It also helps because they'll probably have either between a little to a lot of pain, sometimes often a pretty significant amount of pain as they engage in activities. But this also helps to expose them to a consistent level of pain that they might be living with. However, it's likely to ultimately be less pain than if they were continuing the overdoing, underdoing cycle. Okay, so some tools from DBT, dialectical behavior therapy. So this is an offshoot of CBT, and it's based on behaviorism, mindfulness techniques, and something called dialectics. It was originally developed for suicidal and self-harming women with borderline personality disorder who are not responding to CBT. It's been shown to be effective in treating depression, substance use, and eating disorders, and then also something called emotion dysregulation. The research is actually less developed for chronic pain patients, but I've really found these techniques to be helpful with my chronic pain folks, so I wanted to share them here. Okay, so one tool that I wanted to share was around validation. So validation is finding the kernel of truth in another person's perspective or situation. It's basically just acknowledging that something about the other person's emotions, thoughts, or behaviors is understandable and or reasonable or makes sense in some way. So what can we validate? We can validate the facts of a situation. We can validate the other person's experience, feelings, beliefs, opinions, suffering, difficulties. However, validating doesn't mean that we actually are agreeing or condoning or reinforcing. It's just this idea that before we can create change, it's important to meet the patient where they are, to acknowledge that you understand their experience. And from that place, paradoxically, we're actually much more likely to see change and movement. And so we also want to be careful not to validate the invalid. So what do I mean by this? So when Serena would say things like, nothing is going to ever help my pain, I should just give up. And so I want to validate, you're feeling discouraged about finding ways to help you cope with your pain. I understand you've been at this for a really long time, right? That's understandable that you would feel discouraged. I'm not going to say, yeah, you should probably just give up, right? I'm not going to validate that piece of what she's sharing, but I am going to validate her emotions around it. So why is this important? We actually know that when patients don't feel validated or when they feel invalidated, when their experience is rejected or dismissed or negated in some way, that these are the types of responses that we get from patients. And you can maybe think of examples where you've inadvertently invalidated and seen this response in patients. Sometimes it also happens without invalidation. They've just had those prior experiences before coming to you. And so if we think about validation, what actually happens when patients do feel validated, one of the biggest predictors, for example, with substance use treatment, one of the biggest predictors of success is just the number of sessions that patients show up for. And so even, with validation, even if it just helps them hang in there a little bit longer to be more likely to get a fuller dose of the treatment, if that's effective. So we know that validation really improves our relationships by showing that we're listening and that we understand. It reduces negative reactivity and anger. And it, actually, let me go to my next slide and we'll look at, there's been some research to actually look at the bidirectional experience of both invalidation between patients and providers and the cycle that can happen there. And so this is a really important skill to work on building up, because research actually suggests that there are pretty strong detrimental effects of receiving invalidating or non-understanding feedback, and found that patients who were feeling invalidated were less willing to engage in the treatment, more socially withdrawn, had more negative mood, were more physiologically aroused or worked up in a negative kind of way. And during the stressor tasks in the study, when they received invalidating feedback versus validating or no feedback at all. And so you can check out this study. I put the source here, but we could see this cycle when there's invalidation for patients. So for example, if there's an invalidation of patients, which unfortunately in this population that can be more likely, such as disbelieving or dismissing their pain, that can result in more anger. And actually what was interesting, they found in the study more of a feeling on the part of the patient to want to justify their illness or justify their pain. So then they would actually focus more and more, kind of escalate around that when they were feeling invalidated or unheard. And that also increased hopelessness for patients and avoiding, feeling more isolated. And then they'd be more likely to invalidate the provider from the place of their own emotional pain there. And, with not listening, disengaging, not complying, creating more conflict or discord, criticism, right? And then the provider feels invalidated, and then feels more hopeless, more avoidant, more disengaged, and the cycle continues. Okay, so I wanted to share some language for the patient around how to validate, because this is such an important skill for the provider to validate the patient. So the patient says something like, I just need pain meds, that's the only thing that helps. The provider could say something like, I know you want help managing this pain and I want to support you in that. We don't offer opioids. Here is what we do offer. Have you tried X before? So being very clear about what you do and don't offer, so that if you're clear that opioids are not on the table as a long-term solution in your practice, then there's less likely of a move or an unintentional or intentional efforts on the part of the patient to try and get something because you like opioids when you've already been clear that that's not what you offer in your practice. So being very clear and transparent around that. The patient saying something like, you don't get it, I've been through all this stuff before, I'm just exhausted. The provider could say something like, it makes sense that you feel exhausted given that you've been in pain for so long, and yet you're here today. I see that there's a part of you that wants to find another way to manage this pain. So we're instilling hope, we're reframing that for them. And we're also inviting them to tell us about that part of them that does want something different. Finally, the patient saying something like, doctors just keep telling me to meditate, that's not going to make my pain go away. Provider could say something like, you're feeling like those things won't make any difference. I understand that. At the same time, I can tell you many patients find them helpful. So I can recommend some apps, books, or programs. You can check it out for yourself. Which would you prefer? So then putting it back on the patient to empower, give them that menu of options to choose from. Okay, so a couple more tools from DBT, and then we'll move into the last part of our talk. So one of the DBT tools I wanted to share around a mindfulness tool actually is called the STOP skill. So it's the S also stands for stop. The T is take a step back. The O is observe, noticing what's happening for them internally, thoughts, feelings, sensations, and also what's happening for them externally in their environment. And then the P is proceed mindfully. So it's really encouraging them to move out of a reactive or impulsive mode and to just pause, take a breath, to notice what's going on. You know, pain has this quality of really narrowing attention in a fixed way. And so it's inviting them to step back and broaden their awareness of what's going on in the moment. And then to also think about their goals, like what's going to make this better or worse, what's within my control. And so, for example, you can invite the patient, okay, let's try this together. Let's stop, take 3 breaths. What do you notice inside and outside of your body right now? And what can you do to help yourself this week? So you're moving them into a more solution-oriented frame of mind. I also wanted to talk a little bit about radical acceptance here. So this is a skill that we call on. Radical does not mean on the fringe. It just means, in this case, complete or total. This is a really important skill for chronic pain patients because this is often what they're not in acceptance of, right? That this pain is here and it might be here longer term. I want to be really thoughtful about this skill though, because even though we want to move them in this direction, I really want to highlight that radical acceptance is a process. It's not something that we do just once. This is a way to begin that process or to plant the seeds of radical acceptance. And so we're really, well, yeah, I'll just share some language about that. So for example, you might say, sometimes we can't keep painful events and experiences from coming our way. We can't always control what happens to us, but we can choose how we respond. We can fight against reality, and then that's where our time and energy will go, or we can decide to try and work with what's happening right now. So that's the frame of radical acceptance. That we're accepting the reality that there's pain happening in this moment. It doesn't mean wanting or liking the pain. So that's a really important distinction of radical acceptance. It's not condoning it. It's not approving of it. It's not giving up or giving in. It's not resignation or being passive. It's basically just acknowledging that life can be worth living even with painful events in it, right? We can't eliminate those entirely. It's just part of the human experience. And so really trying to get them to focus on what's within their control to change and what would be helpful to bring acceptance to. So yeah, as I mentioned, the importance of compassion and awareness when teaching the skill. Otherwise, it can come off as dismissive or even invalidating, kind of like a just accept it, it is what it is kind of approach, which is not what we're going for. So we're just, that was some language just to plant the seed. Okay. I wanted to also talk a little bit about, just in the last part of our session today, about managing provider burnout. So this idea of who heals the healer. And the answer to this question, depending on how we look at it, is either no one or we do. And it's challenging to think that no one will engage in self-care for us. You know, this is something I use a lot of radical acceptance around myself. I'm just feeling like, okay, well, I have to provide all of these things for others, and I want to, that's part of my values. And at the same time, that doesn't mean that things are less taxing for me. They're often more taxing. So self-care is really a necessity, not a luxury in the work that we do. And so, yeah, I've been using a lot of radical acceptance around this. So what are some ideas in terms of implementing this? Because this can be really challenging. So the first practical strategy I'll say is actually just around consulting. That just thinking about how often you're consulting and getting support from other providers, or if there are other ways to increase this or get creative around how to get that sense of community and support, maybe something like a monthly lunch consult group or whatever might work for you. And also not just consulting more often, but really thinking about how you're consulting with other providers. So in our DBT team, we state what our issue is and then also what we need around it. Are we wanting some ideas about how to fix it or problem solve it? Or do we just want support or validation? Or do we need some empathy for the patient if we're really struggling there? So you might also just take some time before you consult to reflect on what you actually need, what would be most helpful for you in the moment. The mindfulness, the stop skill, or the breathing that we did at the beginning of the talk, I also have made a practice over time of every time I walk through a doorway, I take a breath, and that's now just become a natural practice for me. As well as a digital detox or technology hiatus that's been shown to be helpful with burnout. One, COVID adaptation. So if you're working remotely, you might consider if there's a way to replace part or all of your time that you had previously spent commuting with some kind of self-care practice. Now, you might need to get buy-in from family members or other involved parties and maybe set some self-care boundaries around this. I also just wanted to take 10 seconds for a couple experiential exercises. So celebrating small victories is one. I'd like you to please write down, I'll really invite you to do this right now in this moment, to fully participate, 3 things that have gone well with patient care recently. Doesn't have to be perfect, just something that went okay even, or better than expected. I'm also going to invite you to reconnect with your own values around this for a moment, and just to check in and ask yourself, how is doing this work that you do consistent with what you value in life? What values are being met by doing this type of work? We also ask our patients to do these types of things. Unfortunately, the tools that work for patients also work for providers. So I'd really invite you to do this practice, or you might even integrate this into your consult group. Okay, and then I also want to make a plug very briefly for mindful self-compassion. This is one of my top tools for reducing provider burnout. We have such high expectations of ourselves and are always trying to do more and serve others better. And then we can get deprioritized. It's this idea you can't pour from an empty cup. So I've included some resource about mindful self-compassion specifically for healthcare providers. A link to that in the Dropbox handout that was on the beginning slide. And then sometimes what's really needed is just to reconnect with empathy. We know that when we don't feel that empathy, or when we lose patience with our patients, that this is very human. And it can also really decrease the quality of care that we provide and increase our burnout. So for example, the patient before you, what is coming out might be help, right? You see help at the top, but that might come out in a way that we might judge as needy or manipulative or dramatic. So just reminding ourselves what might be underneath that help. For example, I'll never get better. They should cure me. I'm useless. I can't stand it. No one believes me. Am I imagining it? And just remembering that this is a person before you who is suffering. And, just like you might also be in this moment, and they're trying to get their needs met the best way they know how. And it might be terribly ineffective, but it still might be the best that they can do in that moment. So how can I bring some radical acceptance to that, a la DBT, or some flexibility to that, a la ACT? What are my options or choices and how I respond? And finally, just take-home points. So using your resources, referring to behavioral health if that's available, to really validate your own and patients, your own struggle as well as patients. that we know that validation can reduce defensiveness and increase collaboration when patients feel heard and when we take a moment to acknowledge that struggle and that pain. Also, this focus on empowering the patient, shifting that onus back to them to help problem solve and partner in their care. Remembering the power of positive reinforcement, especially long-term. So looking for the carrot, not the stick. And then finally, CMEs, consider additional training. And I shared a number of resources in that Dropbox link. So thank you all so much for sharing your time with me. And I know we're actually right at our time for today. I wonder if there's questions that folks have. Maybe they could put those in the chat, and there's a way that we could, I could get a copy of those, Lindsay, or what would be the best option?
Sure, we can get you a copy if they have any, and I don't see any questions in the Q&A function.
Oh, perfect. Okay, so.
Yeah, if anybody has any questions, yeah, please. If anyone has any questions, you're more than welcome to email them to Sam as well, and she'll get them over to Dr. Ortiz to answer. Okay. Well, the webinars are always so hard. You can't see faces, so you don't know.
Yeah, that's true. That's true. Well, thank you all again, and take good care.
All right. Thank you, Dr. Ortiz, and thank you, everybody, for attending tonight's webinar. Again, there'll be a recording available on our YouTube channel, and also you will receive an email with a link to a survey to receive your CME credit. We do have one quick note here, Dr. Ortiz. One of the attendees is asking about the Dropbox slide.
Yes.
Is there a link that you could throw into the chat for her?
Yes, so it is right here at the bottom, this handout resource list, this bit.ly link. I can't copy and paste it off the slide while I'm in presenter view, but it's this bottom one. I can type it out real quick.
Just stay right there and let me just type it out for Dr. Scalapino. Okay. I think I got it.